This is a large retrospective study that I did with my team at the Olivia Newton-John Cancer Centre at Austin Health in Melbourne, and we analysed a number of clinical trials, 42 in total, randomised clinical trials in upfront treatment of diffuse large B-cell lymphoma over the last 30 years, because anecdotally, in my role as a principal investigator of a number of these studies, I have found that the eligibility appeared to be getting tougher. And so we wanted to analyse this in a more objective way. So we looked at the eligibility criteria of these 42 trials, some of which are still ongoing. And then we analysed those according to 3 pre-specified eras. In each of those, we then had a look at the number of eligibility, but also any changes in the strictness of those eligibility criteria. For example, life expectancy, was that changing? Was that being reduced? Was it increasing? Likewise with performance status, was that becoming more restrictive or less? And some of the other more subjective clinical parameters. So we looked at the patterns of those over the 30 years, and we found that there not only is an increase in the number of eligibility in trials for phase 3 studies in treatment-naive diffuse large B-cell lymphoma, examining CHOP-like treatment, but also that some of those criteria were becoming stricter, and there was a definite pattern. We then went on to analyse a clinical real-world population of 200 diffuse large B-cell lymphoma patients treated with R-CHOP, so treated with the control arm of these studies, regardless of their eligibility. And we looked at the proportion of those patients who were eligible for the clinical trials, and we individually matched the patients' clinical parameters with those of the trials, and then we reported the proportion of patients who were eligible in each era. And because of the pattern of increased restrictive criteria, we found that there was a reduced, a downward trend of reduced eligibility. So less of this same population were eligible for current era trials than they would have been if they had been assessed for eligibility 3 decades ago. And that's concerning because for a number of reasons. These are not molecularly based eligibility. These are organ function or patient clinical characteristics. And we know that with the advent of molecular eligibility on top of more restrictive organ eligibility criteria, we have a real problem in that these trials may not be translatable to the clinical population. We may find concerning safety or efficacy signals in the patients who were not represented in the trials. So we really need to have a look at some of these and relax these criteria, which I know there's a real drive to do this by a lot of the large clinical bodies around the world. ASCO have produced statements reflecting this, and some of my colleagues in the US have found similar rates of ineligibility in modern day trials such as the Mayo analysis, which was in the JCO. So as clinicians, we want the data to represent real-world populations, and it is doing so less now than it was 20, 30 years ago, and we need to really reverse that pattern so that we get accurate results. Now, I must say the caveat to that is that we know that phase 1 trials are assessing safety, so populations do need to be fitter. But phase 3 studies, while they do report efficacy, they certainly are mainly to do with, safety. They're certainly mainly to do with efficacy. These are the trials that are changing practice. So we really do need them to be reflective of the population that we want to treat with these agents.